Hi everyone, this is Alex from Salmonella Place, and today's pharmacology lecture is going to be on general anesthetics. So, a general anesthetic helps facilitate surgery by causing analgesia, in other words, loss of pain, amnesia, which is loss of memory, loss of consciousness, inhibition of sensory and autonomic reflexes, which prevent the patient from moving around during the surgery, and skeletal relaxation. There are four main stages of general anesthesia. The first one is analgesia, and as I mentioned, it means that the patient will not feel any pain. However, they are conscious but sleepy. The second stage is excitement. This is when the patient becomes unconscious, but their body still responds to painful stimuli. Inhibitory neurons are inhibited, and then involuntary movements occur. There may be some incoherent speech, vomiting, and irregular breathing. The third stage is surgical anesthesia, and this is the stage that the patient should remain at during the surgery. It's when they have no reflexes, complete muscle relaxation, and regular respiration. The fourth one is medullary depression. This is respiratory arrest and cardiovascular collapse resulting in death. So it's very important that the anesthesiologist maintains a regular dose to the patient to keep them unconscious and free of pain, however, not to overdose them because there can be serious consequences. Now I'm going to talk about the first subtype of general anesthetics, which is inhalation anesthetics. These are lipid-soluble molecules which affect the cell membranes and the cell membrane proteins. They inhibit the excitatory transmission through glutamate and nicotinic acid, and they inhibit the potentiated transmission through GABA. This happens by pumping the anesthetic through a machine into the lungs, and then it spreads from the blood into the tissues. It's really important that there's an equilibrium between the drug concentration and the alveolar spaces and the capillary blood. And this is known as the MAC, or the minimum alveolar concentration, which is needed to cause respiratory depression and induce the need for artificial ventilation. So this is the level of anesthetic that needs to be administered so that the patient is prepped and ready for surgery. These kind of drugs are volatile fluids, vapors, and gases. They have a negative ionotropic effect, which decreases the cardiac output. And as a result of that, there's a decrease in blood pressure, vasodilation, and increased intracranial pressure. There are some serious side effects as well, such as malignant hypothermia and an extremely high calcium ion release. So the first drug is ether, which is not really used anymore due to its flammability and airway irritation. However, when it was used, it was lipophilic, it had a low AMC, and it did cause, in some cases, malignant hypothermia as a side effect. Nitric oxide is only a gas, and it cannot produce deep anesthesia, so it's used in conjunction with other anesthetics. It doesn't have serious side effects, but very rarely it can cause bone marrow suppression. Halothane is potent but non-irritating, and it helps maintain anesthesia in long surgeries. It does, however, have the side effects of hepatotoxicity, cardiorespiratory depression, arrhythmia, and sensitization. It is lipophilic and has a low AMC. I just want to note here that the lower the AMC is, the better, because it means that there's a lower dose of drug in the body that induces the state of surgical anesthesia. Next is enflurane. That has a low lipophilicity and it maintains anesthesia with nitric oxide. Isoflurane, desflurane, and sevoflurane, they have fast kinetics. They're not very lipophilic, and not very potent, and there are no side effects. So now we are on to the second group of general anesthetics, known as intravenous anesthetics. And before I go through the drugs with you, I'm just going to tell you a little bit about the methods and modes of action of these drugs. I just want to apologize in the previous slide. A couple of times I might have said AMC instead of MAC for the minimum alveolar concentration. So please don't get confused about that. So intravenous anesthetics, they potentiate GABA and produce central nervous system depression. The MAC, or minimum alveolar concentration, is low in these anesthetics, and this is equivalent to the low concentration of a drug used in the anesthesia. This is because of their high lipophilicity, and that makes them very potent. They are short-acting drugs which induce anesthesia and then are maintained by an inhalation anesthetic. So first you would give an intravenous anesthetic to knock the patient out, and then during the surgery, they will be maintained in that state by the previous subgroup, the inhalation anesthetics. So their induction is maximum 1 minute. They have a short excitement phase, a fast recovery, and they are redistributed within the body. First, we give it through an IV injection, and that rapidly increases the blood concentration of the drug. However, there is a rapid decline because of the organ perfusion, like I mentioned before, the redistribution, and because of muscle perfusion. The large muscle mass and the circulation of the drug causes its rapid decline. However, after the initial rapid decline, where most of the drug is redistributed, there is a slower decline through hepatic metabolism and renal excretion. However, most of it, like I said before, is eliminated by redistribution, but it hasn't left the body completely. The duration of action is between 5 and 10 minutes. So the first of these drugs are barbiturates, like thiopental and methohexital. They're lipophilic and they have no analgesic action. However, their side effects include cardiorespiratory depression. Ethomidate is given if a patient has hypovolemia or shock. Propofol is the most commonly used drug. It's rapidly metabolized and there's no accumulation in the tissues. You have to give a continuous infusion of propofol, and the side effects include cardiorespiratory depression and hypertension. Ketamine produces surgical anesthesia alone, so it doesn't need a second drug to help maintain it or induce it. It's used in short procedures, and it's a dissociative anesthesia. The patient is conscious but insensitive to pain. It stimulates the cardiovascular system. However, it can cause hallucinations. Opioids, such as fentanyl, can be used in a high dose. And finally, benzodiazepines, such as diazepam, which is an anti-anxiety drug, is used prior to the surgery. Neuroleptic anesthesia is an intravenous combination of fentanyl and droperidol. It is like dissociation anesthesia, which I mentioned previously when talking about ketamine, which is also a dissociative anesthesia. That was under the subtype of intravenous general anesthetics. Balanced anesthesia is a mix of drugs in low dosages, which decreases the risk of toxicity of a single drug. It is an intravenous dosage given of nitrous oxide and other vapors, and an extra relaxant and some opioids. Pre-anesthetic medication includes benzodiazepines, opioids, H2 receptor antagonists, and atropine. Benzodiazepines and opioids are used to relax the patient in a preoperative state. H2 receptor antagonists prevent gastric juice aspiration, and atropine decreases the parasympathetic effects.